Welcome everybody to the ICS Workshop on Demand number 24, Neuromodulation in the Management of Lower Urinary Tract Dysfunction, Current Best Practice, Innovation and the Future. My name is Arun Sahai. I'll be chairing the workshop. I work at Guy's Hospital in London. We'll be joined today by an international well-renowned faculty, Marcio Averbeck from Brazil, Roger Dmochowski from the United States of America, and Sachin Malde from the UK. The aims and objectives are to review the current status of neuromodulation in managing lower urinary tract dysfunction with a particular focus on evidence from the last 5 to 10 years. We'll also discuss ways of optimizing neuromodulation for the benefit of patients and talk about the new innovations in technology in the field. The program is highlighted here. We're soon going to start with insights into mechanism of action, and then we'll go through the main uses, essentially in refractory overactive bladder, voiding dysfunction, neurogenic lower urinary tract dysfunction, bladder pain, interstitial cystitis, and chronic pelvic pain syndrome. The last two lectures will focus on optimizing the techniques, patient selection and programming, and finally we'll hear about the new technologies, innovations, and some views on the future. We really hope you enjoy the workshop, and please don't hesitate to ask questions through the interactive portal.
Thank you, Arun, and to the ICS for inviting me to do this talk, and it's an honor to be part of this ICS workshop. So I'm going to be talking about the current knowledge and recent insights into mechanism of action of neuromodulation with a focus on sacral neuromodulation as the best studied modality. These are my affiliations. So for years it has remained unknown how the same treatment implanted in the same way using the same stimulation parameters can be successful in treating such heterogeneous conditions with seemingly opposite pathophysiologies. So for example, on the one hand, voiding too frequently, and on the other, not voiding at all. And so the mechanism of action of neuromodulation has been an enigma for many years. But advances in technology and imaging and recent studies in animal models of these conditions have given us a much greater understanding of the complex neural network that controls the lower urinary tract, and that has led to suggested possible explanations of how neuromodulation may work. So in order to understand how sacral neuromodulation may work, I think it's first helpful to revisit the neural control of the lower urinary tract during storage and voiding phases and how this changes in disease states. And this diagram from a paper from Bertil Bloch shows the current understanding of the neural control of micturition. So there are two principal pathways involved. Firstly, the reflex pathways of the spinal cord that are intrinsic to the processes of storage and voiding. And then secondly, there are the supraspinal or cerebral pathways which modulate these spinal reflex pathways. So during the micturition cycle, continence is achieved by the guarding reflex, which consists of information from the bladder and urethra being transmitted through afferent A delta fibers via the pelvic nerves to the sacral spinal interneurons, which then stimulate sympathetic outflow in the hypogastric nerve, resulting in relaxation of the bladder smooth muscle, inhibition of parasympathetic activity on the bladder, and contraction of the outlet. Contraction of the sphincter during filling also activates inhibitory interneurons in the sacral cord, which suppress reflex bladder activity, promoting continence. So this is all under autonomic involuntary control, but at the same time, information is also passed to the pontine micturition center, the periaqueductal gray, and higher areas in the forebrain, which control the periaqueductal gray and the pontine micturition center, and are responsible for the voluntary control of allowing voiding at a socially convenient time. So without this input from the periaqueductal gray and cerebral areas, reflex voiding with urgency incontinence results as soon as afferent signals reach a certain threshold in the periaqueductal gray. as seen in the animal studies when the pontine micturition center and periaqueductal gray are disconnected. So that suggests that there's a tonic inhibition of the periaqueductal gray input to the pontine micturition center during the storage phase. When voiding is desired, increased activity in cortical areas, such as the prefrontal cortex, the insula, the hypothalamus, and the periaqueductal gray, is seen on functional MRI studies, and that leads to activation of the pontine micturition center, and therefore urethral relaxation, followed by bladder contraction. So this is thought to be due to a release of that tonic suppression by the prefrontal cortex of the periaqueductal gray input to the pontine micturition center. So what happens in overactive bladder? Well, there are several hypotheses about how the symptoms of urgency and urgency incontinence may occur, and these come down to two principal processes. Firstly, increased afferent activity, and secondly, abnormal handling of afferent signals in the brain. Increased afferent activity may be due to changes in sensory signaling at the level of the urothelium or suburothelium, that's the urotheliogenic hypothesis, or to changes to the excitability and coupling of smooth muscle cells with other myocytes or interstitial cells, leading to uninhibited contractions, myogenic theory. Neurological damage may unmask primitive voiding reflexes, or alternatively, for some patients, overactive bladder symptoms may be due to abnormal handling of afferent input in the brain. So-called brain OAB has been suggested by recent PET and functional MRI studies showing diminished responses in areas responsible for voluntary voiding, specifically the prefrontal cortex. So it's thought that white matter disease is one factor responsible for these changes, and this may be due to cerebral ischemia, hyperperfusion, or blood-brain barrier dysfunction. In overactive bladder, PET and functional MRI studies of normal controls and those with OAB have shown that there are differences in regions of brain activity in those with OAB. So this study from Pittsburgh found a correlation between the degree of bladder filling and insular activation in healthy controls, with an exaggerated increase in activation at high volumes in those with urgency incontinence. As well as these central changes, sensitization of previously silent C-fiber mediated spinal reflexes also occurs, so there's an emergence of a peripheral reflex pathway. And the importance of understanding this is that these two processes are thought to be areas on which sacral neuromodulation may act. In patients with non-obstructive urinary retention, there is abnormally increased external urethral sphincter afferent activity which inhibits micturition, so it's an exaggerated guarding reflex. And PET and functional MRI studies have shown that on bladder filling, there is also deactivation of widespread brain areas that included the insula, which is responsible for awareness of bladder sensation. And this fits with the lack of sensation that most patients with non-obstructive urinary retention report. With a full bladder, responses remained abnormal, but deactivation was less widespread, and there was some activation of scattered brain regions which were with partially restored sensation. So where in these pathways does sacral neuromodulation have an effect? Well, this review summarized the data looking at mechanism of action of sacral neuromodulation, and it's thought that it has both peripheral effects on afferent pathways as well as central effects on spinal cord reflexes and brain centers. Early theories assumed that the stimulation of motor nerves resulted in pelvic muscle contraction, resulting in relaxation of the bladder wall, but it's now known that this is not true. And studies such as this one, assessing urodynamic parameters after successful sacral neuromodulation, show that in patients with Detrusor overactivity, sacral neuromodulation suppresses this Detrusor overactivity without affecting urethral resistance or Detrusor contraction strength. So it's now thought that sacral neuromodulation has both peripheral and secondary central mechanisms of action. And stimulation of somatic afferent nerves from the bladder modulates spinal reflex pathways and brain networks. Support for this hypothesis comes from animal and human studies. This study showed that early bilateral sacral neuromodulation during the acontractile phase after a complete spinal cord injury actually prevents the development of detrusor overactivity and detrusor sphincter dyssynergia, and this was maintained at up to 3-year follow-up. And it's thought that this may be due to preservation of nerve plasticity, thereby preventing the emergence of these C-fiber-mediated reflex pathways which lead to detrusor overactivity. Recent animal studies of early sacral neuromodulation in animal models of complete spinal cord injury have confirmed this effect, showing that you can have improved bladder function with better capacities and lower detrusor pressures at voiding, and avoiding the emergence of detrusor sphincter dyssynergia. But on top of that, structural assessment of the bladder showed that sacral neuromodulation resulted in a higher amount of smooth muscle tissue and less connective tissue increase after spinal cord injury compared to controls. And similar results were seen with acute sacral neuromodulation in non-neurogenic settings with acetic acid-induced DO in pigs, and a recent animal study of tibial nerve stimulation confirmed statistically significant changes in bladder function, which were only seen at stimulation amplitudes that electrically recruited the unmyelinated C fibers, again supporting the hypothesis that neuromodulation has an effect on afferent C fiber-mediated pathways. So how about its central effects? Well, the earliest study to evaluate the supraspinal effects of neuromodulation used PET-CT and found that changes in brain activity were observed in regions associated with alertness, the sensation of bladder filling, and timing of micturition when the neuromodulation stimulus was compared to when it was off. These areas included the prefrontal cortex, the cingulate gyrus and thalamus, but interestingly there were no changes seen in the periaqueductal gray or pontine micturition center, suggesting that sacral neuromodulation exerts its effects through other areas of the voiding pathway. And 2 recent functional MRI studies have confirmed these early findings. The study from Weisbert found that compared with non-responders, patients responding to sacral neuromodulation had increased activity in the cingulate cortex, inferior frontal gyrus, insula, and thalamus before implantation, and following implantation, brain activities in all these areas were diminished. The study from Gill assessed functional MRI whilst the sacral neuromodulation device was cycled off and on, and demonstrated that differences in brain activity depending on the level of stimulation, so subsensory stimulation deactivated the pons and periaqueductal gray, whilst sensory stimulation deactivated the parietal lobes but activated the insula, and suprasensory stimulation led to widespread activation, including increasing activity in the somatosensory region. So overall, these data confirm that sacral neuromodulation alters CNS activity via afferent neural pathways. And the changes in brain activity seem to vary with the strength of stimulus and might relate to altered neural activity at baseline. So how is sacral neuromodulation thought to work in non-obstructive urinary retention? Well, functional MRI studies of neuromodulation in patients with Fowler syndrome showed that sacral neuromodulation partly normalizes responses in Fowler syndrome patients, leading to activation instead of deactivation of certain brain areas, such as the insula. Without sacral neuromodulation, bladder filling failed to produce detectable periaqueductal gray activation, but this was restored by sacral neuromodulation. And this is supported by animal data in a cat model of Fowler syndrome, which showed that neuromodulation blocks the increased bladder capacity induced by pudendal nerve stimulation, supporting the hypothesis that sacral neuromodulation treats non-obstructive urinary retention by blocking the inhibition of micturition that's induced by abnormal external urethral sphincter afferent activity. And finally, recent data from animal studies has shown that the mechanism of action varies depending on the stimulation frequency used. So high-frequency stimulation of the pelvic nerve in rats at a level of 1 to 3 kilohertz led to complete suppression of voiding. Another study showed that pudendal nerve stimulation at 5 Hz increased bladder capacity to about 200% of control capacity, and pudendal nerve stimulation at 20 to 30 Hz induced large bladder contractions. This was also seen with tibial nerve stimulation, where 5 Hz induced bladder underactivity by significantly increasing capacity, whilst 1 Hz stimulation normalized the contraction amplitude and significantly reduced the capacity. This again adds further evidence that tibial nerve stimulation at different frequencies might be used to treat bladder underactivity and overactivity. The variable clinical effect, depending upon stimulation frequency, has also been seen in clinical studies, with 14 Hz having greater improvement in OAB parameters than 5.2 Hz. So, in conclusion, the mechanism of action of neuromodulation involves complex pathways, and it's still not fully understood. But effect on afferent pathways are thought to be a key mechanism, resulting in modulation of spinal reflexes and brain centers. And the mechanism is likely to be different depending upon the indication and stimulation parameters used. Thank you. So this talk will summarize the evidence for neuromodulation in the treatment of refractory overactive bladder, focusing on recent literature and key evidence. These are my disclosures. So we'll first review the guideline recommendations, then we'll discuss the recent evidence for tibial neuromodulation, sacral neuromodulation, and finally briefly discussing emerging data for pudendal neuromodulation in refractory overactive bladder. So what do the guidelines recommend? Well, for sacral neuromodulation, most guidelines recommend that this be considered an option after failure of conservative and pharmacological treatment. And this is seen here in the EAU guideline algorithm for the management options after failure of conservative or drug therapy. And similarly, in the latest international consultation on incontinence algorithm. With a grade B recommendation from the ICI that sacral neuromodulation is effective in those with refractory urgency, frequency, or urgency incontinence. And similarly, the AUA, however, give a recommendation that clinicians may offer sacral neuromodulation as a third-line treatment in those with severe refractory OAB symptoms who are not candidates for second-line therapy and are willing to undergo a surgical procedure with an evidence strength grade C. So that's for sacral neuromodulation, but how about tibial nerve stimulation? Well, the EAU reports level 2B evidence that PTNS is effective in patients who have failed pharmacological therapy and given a grade B recommendation to offer PTNS as a short-term option for improvement, although not cure, for these patients. Whereas PTNS is considered a third line in the AUA SUFU OAB guidelines. So let's look in more detail at tibial neuromodulation first. So there are 3 ways of really stimulating the posterior tibial nerve, namely transcutaneous, percutaneous, and implantable. But here we're going to focus on percutaneous tibial nerve stimulation as it's in the guidelines, and implantable tibial neuromodulation will be discussed later in this workshop. So PTNS has demonstrated efficacy in refractory overactive bladder. This recent systematic review of 16 studies and 640 patients reported overall efficacy ranging from 37 up to 100% at short-term follow-up, so very wide-ranging. And this review, however, with more stringent inclusion criteria, reported solely on RCTs. And the review included 4 randomized trials of PTNS in refractory OAB, comparing PTNS to sham or placebo, antimuscarinics, and vaginal electrical stimulation, with success rates reported from 55 to 80%. But again, the studies were all at short-term follow-up. And these efficacy rates were confirmed in the most recent and thorough systematic review and meta-analysis of 28 studies with almost 2,500 patients from 12 of which were randomized controlled trials. They did report significant heterogeneity in terms of the treatment schedule and the relatively short follow-up, but overall reported that PTNS does achieve a mean reduction in frequency episodes of 2.4, nocturia episodes of 1.5, urgency episodes of 2.2, and incontinence episodes of 1.6 per day. And if we focus on the RCTs, the overall success rate was 68%, but in the RCTs, success rate objectively was still 66%. In terms of long-term outcomes, the STEP study, which is a prospective cohort from those successful in the Summit RCT, reported that 77% of patients had maintained efficacy at 3 years, but the number of patients followed up to this time was relatively small at 29. A recent larger study, however, assessed long-term outcomes in over 400 patients, and it was found that 57% had initial success based on a decision to continue PTNS treatment after the initial 12-week treatment period. But more interesting was the finding that only 32% of all patients who continued treatment after a good response to the initial 12-week treatment continued for a longer period with a maximum follow-up of 111 months, a median 14 months. And more than 40% of patients discontinued treatment after 6 years for non-medical or logistical reasons, even though they felt the treatment was beneficial. So now we'll look at sacral neuromodulation. So the most studied device is the Medtronic Interstim 2, and the initial approval data is well known. So I'm going to focus really on recent efficacy and safety data and recent key evidence comparing sacral neuromodulation to intrathecal Botox. So this recent review assessed the results of RCTs of sacral neuromodulation, which included a minimum of 20 patients and with a minimum 6-month follow-up. 5 RCTs are included, 4 comparing sacral neuromodulation to standard medical therapy, and 1 comparing sacral neuromodulation to Botox. The key finding is that the overall success or improved rate was 61 to 90%, but this did depend on various factors, including the baseline severity of incontinence and the definition of success in the trials. And furthermore, follow-up was short-term, the majority 6 months, in these RCTs. In recent years, however, a greater amount of long-term data has emerged, and this study from Siegel is the prospective long-term follow-up from the INSIGHT RCT of 272 patients that underwent a full implant after a successful test phase. Now, the reported success rate at 5-year follow-up was 67%, with a success rate specifically in those with urgency incontinence of 64% and a completely dry rate of 38%. In terms of adverse events, the most common device-related adverse events were an undesirable change in stimulation in 22% and implant site pain in 15%. And these results confirmed those of an earlier long-term follow-up cohort study, which reported 5-year success rates of 62% and continence rates of 15%. This recent study of a large number of patients treated with sacral neuromodulation reported on predictors of reoperation. And overall, it was reported that the reoperation rate was 33% over a median 29-month follow-up, of which 19% were revised, 14% were explanted, most commonly due to lack of efficacy or worsening symptoms. This further study analyzed data from the INSIGHT trial, focusing on the device-related adverse events within the first year. Overall, device-related adverse events occurred in 30% within the first year, the vast majority within the first 3 months. And the commonest adverse events were an undesirable change in stimulation of 12%, implant site pain in 7%, and infection in 3%, with an overall reintervention rate of 13%, mainly for pain, lack of efficacy, or infection. So how does sacral neuromodulation compare to the other recommended treatment option for refractory OAB, which is intrathecal Botox? Well, this well-known multi-center open-label randomized trial compared sacral neuromodulation to 200 units of intrathecal Botox, the Rosetta trial, in women with refractory overactive bladder who had more than 6 urgency incontinence episodes over a 3-day period. And it was found that both treatments resulted in sustained and similar reductions in mean daily urge incontinence episodes, but Botox participants were more likely to have complete resolution of urgency incontinence in the first 6 months, with higher satisfaction and treatment endorsement throughout the 24-month period. But overall, there were higher rates of complications with Botox, with recurrent UTIs in 24%, need for CISE in 6%, and the neuromodulation revision rates were relatively low at 3%, with 9% requiring removal. Interestingly, in those with refractory OAB that initially undergo and fail treatment with Botox, the efficacy of neuromodulation is no different to that reported for those who undergo sacral neuromodulation as a first choice, with a success rate of almost 60% in this cohort after failed Botox. So in the absence of a lot of other head-to-head evidence between the different options for treating refractory OAB, this nice network meta-analysis assessed 17 RCTs that compared any dose of Botox against sacral neuromodulation and Ptns with each other or a placebo, with a follow-up of 3 to 6 months. And it was found that all 3 modalities were effective in managing OAB, and all were better than placebo. But at short-term 12-week follow-up, it was found that sacral neuromodulation yielded the greatest reduction in urinary incontinence episodes and urinary frequency episodes per day. Botox treatment resulted in a higher incidence of complications, including urinary tract infections and urinary retention. So how about Pudendal Neuromodulation? Well, this study from Peters reported outcomes from direct stimulation of the pudendal nerve through an ischiorectal approach, and success rates of 71% were reported, and impressively 93% of those who had failed sacral neuromodulation responded to Pudendal Neuromodulation. And I think that this is a promising approach, and it does require further investigation in well-designed trials to determine the place of Pudendal Neuromodulation in the treatment pathway for refractory OAB. So in conclusion, neuromodulation is a well-established and recommended option for refractory OAB. Ptns has modest efficacy with minimal adverse events. Sacral neuromodulation is well established with demonstrable long-term efficacy, but higher long-term device-related adverse events. And there is a paucity of head-to-head studies comparing the treatment options for refractory OAB, and so this is an area for future study. Thank you.
Good day. I'm Roger Dmochowski. I'd like to present to you today neuromodulation for voiding dysfunction. I'd like to thank Dr. Sahai for including me in this session. These are my affiliations. I am self-funded for this meeting. As we consider neuromodulation for voiding dysfunction, I can safely say that there has now been a change in the sea wind of philosophy related to the management of lower urinary tract dysfunction with neuromodulation. This is a statement from the most recent AUA guidelines on the management of overactive bladder. And as you can see in the highlighted text, the clinical framework no longer requires that every patient go through each line of treatment prior to progressing to the next. And this is largely done in reference to ongoing and accruing information related to voiding dysfunction and some of the side effects and adverse events that we are now seeing with some of our longer-term therapies, specifically the antimuscarinic oral therapies. We're seeing the evolution of PTNS, and obviously, as you can see in the final ultimate statement in this paragraph, PTNS can be considered in drug-naive patients who opt to forego pharmacotherapy, which is a significant sea change in the philosophy of the way we approach overactive bladder. I was asked today to speak for neuromodulation for voiding dysfunction. We know there are a variety of worldwide approved indications for neuromodulation, including OAB wet, in other words, urgent incontinent patients, OAB dry, patients who are urgency frequency. Obviously, this group may span also those patients who may have some component of pelvic floor or pelvic pain dysfunction, and non-obstructive urinary retention, which is a very difficult catchment group, and frankly, the one where I personally have seen less of a benefit for neuromodulation as compared to the other two populations. It exists, but is unfortunately less so. There are a variety of non-approved indications for the current systems for overactive bladder, including neurogenic overactive bladder, although data certainly exists in the multiple sclerosis population and to a lesser degree in the Parkinson's population for neuromodulation. Also, bladder pain syndrome, IC, interstitial cystitis, is another off-label indication. Certainly many of us use neuromodulation for the urinary storage symptoms associated with that condition. And then finally, we have the functional disorders, including the Hinman disorders, which are probably sphincteric dysfunction related to learned voiding misbehavior. Again, those are not necessarily approved, but certainly could fall under the rubric of non-obstructive urinary retention. And again, we do have some data to support those. Given the short time I have with you today to present the data, I'm going to take a very high-level view of some of the most recent data. As we know, neuromodulation continues to evolve. The therapy is rapidly changing. We are seeing smaller devices, specifically IPG changes in terms of both the overall size of the canister as well as the internal power source. We're also seeing the evolution of extended life power sources with recharging capabilities. Very important advent has been the recent development of MRI compatibility, and also the use now of wireless technologies for the purpose of not only sacral but also peripheral and neuromodulation as it pertains to the conditions that we are most concerned with in pelvic floor disorders. This is simply a summary slide of the currently available S&M systems and the primary versus rechargeable battery issues associated with them. And these are the three systems that are currently available. InterStim 2, InterStim Micro, and the axonic system. As you can see, they vary between a primary cell versus rechargeables. You can see that we're now seeing extended life with recharging of up to 15 years with very small IPG volumes and MRI compatibility, in some cases up to 3 Tesla. So this is really now becoming very much more functional for patients who may be considering or who may need subsequent neurologic workup of utilizing MRI scanning. We know from recent data at 2 years with the rechargeable systems that there is retention of effect over time, which remains relatively robust, as you can see from the data from the Relax OAB axonics trial. And I'd like to focus on, as you have heard a lot about overactive bladder and neuromodulation in the prior sessions, as you can see, urinary frequency, which is the OAB dry population, is less robust in terms of its overall effectiveness, but nonetheless, from a historical context, 70% benefit is still what we consider to be a historical gold standard as a reasonable benefit for these patients. Obviously, this OAB dry population may also include, again, some penumbra into the IC and pelvic pain syndrome population in terms of bladder storage issues. We know that patients are very satisfied with the recharging capabilities, and the patient charging experience, as you can see, actually is not only easy but also acceptable to the patients, both in terms of the duration of charge retention as well as the frequency of recharging needed for this. So it does appear that recharging, whether it's being done from a central nervous system standpoint, a sacral nervous system approach or a peripheral nervous system approach, does appear to be acceptable to patients. We know that associated with tibial neuromodulation, that there's been a lot of work brought forward with this. This is a new form of afferent stimulation. And we know that from the standpoint of afferent stimulation, we can see that there is a direct interaction not only at the sacral core level but also at the pontine center, and we now have substantial evidence that tibial neuromodulation as a peripheral option to SNS may indeed be a very reasonable consideration, at least for some of our patients with voiding dysfunction. We know and have a lot of data related to Ptns, percutaneous neuromodulation. This dates all the way back to the original Urgent device in 2004. We now know that there's a newer device that Medtronic has been utilizing called the Neuro device, and there's been a variety of studies that demonstrate the effectiveness of percutaneous tibial neuromodulation for patients with overactive bladder, both compared to placebo, a sham, as well as to ingestion of antimuscarinic agents. And the demonstrated benefit has been shown with this particular type of neuromodulation. Recent data from the Neuro device, which was performed on looking at patients who were, interesting enough, naive to OAB medication. 120 patients were included. Interesting enough, 23% of patients took longer than 8 weeks to respond. At week 12, 70% urinary incontinence reductions were noted across the population, and 90% of patients actually reported reduction of severe or very severe symptoms. Very interesting and important data related to neuromodulation from a tibial standpoint. We now know that implantable tibial neuromodulation is being explored substantially with multiple systems. All systems directly access a tibial nerve, but there are subtle differences between the systems. These are the four systems: Bluewin, Micron, Valencia, and Bioness, and they're all subtly different in their access and management of control of the tibial stimulation pathway, but each one has its either open or closed loop aspects, and some of these symptoms rely on a single component that's implanted with an external wearable device versus the Valencia system, which is a completely enclosed non-wireless device that's implanted as well. We also are seeing now the development of other types of peripheral afferent neuromodulation, including saphenous, and now even perineal nerve stimulation that have been reported certainly in animal models and in some cases in some very small human trials. And this just gets to the point that afferent stimulation clearly has a role in the modulation of these patients with overactive bladder and pelvic floor dysfunction. The issue is, who are they and how best to determine them? Finally, there is a new system, which is an implantable device, which is a pessary-based device, which is called the FemPulse device, which is basically stimulates the autonomic nerves around the paracervical region, the base of the bladder, obviously where there's a rich pelvic ganglia autonomic plexus. And this has shown early promise and obviously is now being investigated in subsequent clinical trials. So it goes. This is a technology that's rapidly evolving. Interesting enough, it's becoming much more patient-centered and allows patient interactivity with the device. There are limitations based upon our incomplete understanding of the condition that we're dealing with. And we really now must look at segmentation of those patients with voiding dysfunction based upon population parameters. And how we segment this population may be based upon biologic, psychologic, or other factors in combination. But nonetheless, it's clear that patients need to be optimally engaged with these therapies, and patients need to be very much involved with the management of these therapies as we move forward in terms of the treatment of our patients with overactive bladder. Thank you very much.
Hi, everyone. My name is Marcio Averbeck, and today I'm going to talk about neuromodulation for neurogenic urinary tract dysfunction. Let me share my slides with you. These are my disclosures. Firstly, I'd like to tell that I'm very happy to take part in this very special workshop with several colleagues and friends, this expert panel, which is today bringing you insights on neuromodulation for the ICS 2020. I am a urologist and I'm working in the main city of southern region of Brazil, Porto Alegre. Let's move forward. I would like to present a brief introduction starting with the manufacturer's consideration on sacral neuromodulation. As you can see here, sacral neuromodulation has not been established in terms of safety and effectiveness for patients with neurological diseases and urinary tract dysfunction as a consequence of this neurological disease. So does neuromodulation make sense in patients with neurogenic urinary tract dysfunction? This is an important question. As we know, the first-line medical treatment for neurogenic Detrusor overactivity are the antimuscarinics according to the incontinence book with a level of evidence 1. However, more recently, several barriers have been imposed considering the use of antimuscarinics in the clinical practice, including the association or potential association with this class and the risk of dementia. By adding antimuscarinics and dementia to the PubMed, as you can easily see, there are several references more recently published, more than 700 actually in the last few years. One of them was this study published by Copeland et al. On JAMA Internal Medicine. As you can see, these authors have linked the cumulative use of drugs with anticholinergic burden with the new onset of dementia. These outcomes are important, but on the other hand, we should be aware of the fact we cannot still establish causality out of these retrospective and perspective series that tried to demonstrate an association. Nevertheless, this potential association causes much worries in the clinical practice. Which are the treatment options for refractory neurogenic Detrusor overactivity? As you can see from the 6th ICI algorithm, we have several options, including botulinum toxin A, distinct neuromodulation techniques, and the enterocystoplasty for specific indications. However, this was one of the studies from the real life showing that the long-term compliance with botulinum toxin A was rather low, around 25% according to these authors. And patients with neurogenic OAB symptoms appear to have the best results in this study. However, we should be all aware about this. The topics of my lecture include all these listed in this slide, and we'll start with relevant definitions. From the terminology for adult neurogenic urinary tract dysfunction by the ICS, we know that direct electrical stimulation, neurostimulation, is the direct stimulation of the nerves or neural tissue to effect function of the end organ. As an example, we have anterior-sacral root stimulation, SARS, which causes the Detrusor contraction. On the other hand, electrical neuromodulation is the stimulation of the nerves or neural tissue to modulate function and induce therapeutic response of the urinary tract. An example, we have the pudendal nerve stimulation, which may cause the Detrusor inhibition. There are other relevant definitions, including the neurogenic overactive bladder. This is a new one published in 2017, which is characterized by urgency with or without urgency urinary incontinence, usually with increased daytime frequency and nocturia in the setting of a clinically relevant neurological disorder with at least partially preserved sensations in the lower urinary tract. Detrusor sphincter dyssynergia describes the detrusor contraction concurrent with an involuntary contraction of the urethral or periurethral striated muscle. Let's move forward. What about non-invasive neuromodulation techniques? There are several in different modalities of non-invasive neuromodulation for urinary tract dysfunctions, including all these: endogenital stimulation, transcutaneous, percutaneous tibial nerve stimulation. Let's focus on the Ptns. By adding percutaneous tibial nerve and neurogenic bladder, I found 28 results on PubMed. And this is one of the recently published studies by Tudor et al. Showing that, according to this series, the most common indications for PTNS among patients with neurological diseases were urinary tract dysfunctions related to multiple sclerosis and Parkinson's disease. As you can easily see in this table, there was no difference, no statistically significant difference between the outcomes for patients with idiopathic versus neurogenic OAB according to this series. The conclusions were that percutaneous tibial nerve stimulation appears to be a promising alternative for patients with neurological disorders. However, proper design studies are still required to address safety and efficacy. What about PTNS for Parkinson's disease, by the way? As you can see in this table, there are some series which were published in the literature. I found this one which included urodynamic studies before and after PTNS, showing that for various urodynamic parameters, there were statistically significant changes after PTNS. Those are promising results, but if you move to the overall studies that we can find in the literature, we know that there were limited number of patients, lack of comparative studies, and a very restricted follow-up. What about sacral neuromodulation outcomes for neurogenic urinary tract dysfunction? Let's start with this very provocative question. Is there a role for sacral neuromodulation to prevent neurogenic detrusor overactivity in spinal cord injured patients? This is a study that you might be aware of, published by Sievert et al. Many years before in 2010, showing that in a very restricted number of patients, early sacral neuromodulation helped prevent or maybe delaying the onset of detrusor overactivity in these patients with complete lesions. This is only a pilot study, and more recently, this was a study protocol published to properly assess and to provide a more direct response to the question I've just made. So this is being proposed by Dr. Redshaw et al., and this study is currently ongoing, and we are looking forward to check these outcomes. Results of sacral neuromodulation according to the underlying neurological disease. You might know this systematic review and meta-analysis of the literature, which has been published by Thomas Kessler et al. On European urology. And as you can see here from the outcome tables, the outcomes for the test phase in terms of success rates range from 29 to 100% across different neurological disorders. And the outcomes for the permanent implant range from 50 to 100%, as you can see on the right side here. So the authors concluded that the overall success rate was 68% for the trial phase and 92% for those who received the implant with a mean follow-up of 26 months. So these are very promising outcomes, and we had a chance to review all the literature published from 2011 to 2019. And we found that in most series of patients with neurological diseases, there were several limitations, including the lack of standardized criteria for indications, but not only that, but also the definition of the success of the trial phase, the criteria for the successful clinical outcomes were quite heterogeneous, and of course there were short-term follow-up. As take-home messages, I would like to bring these ones to you. There are unmet needs regarding indications and outcomes for different neuromodulation techniques for patients with neurogenic urinary tract dysfunction. However, low level of evidence studies suggest that Ptns and sacral neuromodulation may be promising treatments for selected patients. Of course, further research and diffusion of new technologies are still needed. Thank you very much for your attention.
The next lecture is on neuromodulation for bladder pain, interstitial cystitis and chronic pelvic pain syndrome. My name is Arun Sahai. I'm a consultant neurological surgeon and honorary senior lecturer at Guy's Hospital and King's College London. These are my disclosures. The objectives of the lecture are to discuss the rationale for treatment of bladder pain and chronic pelvic pain with neuromodulation. We'll review some key papers from the literature, and we'll give you all some thoughts about the future. This nice review by Roy et al. Really summarizes quite nicely the rationale for neuromodulation for pelvic and urogenital pain. Sensory afferent information from the colon, bladder and urethra are transmitted by the splanchnic, pudendal and pelvic nerves, whose cell bodies are in the dorsal root ganglia at the levels of the lumbosacral and thoracolumbar cord. Pain from the bladder is transmitted via visceral afferent nerves travelling with the sympathetics via the hypogastrics and the lower segments of the bladder via sacral parasympathetics in the pelvic nerve. In general, it's fair to say that upper pelvic viscera come from the sympathetics and lower pelvic viscera, for example the upper vagina and cervix, via the parasympathetics. Ultimately, the visceral afferents synapse onto second-order neurons in the dorsal horn of the spinal cord. Then they ascend via spinothalamic tracts or the dorsal column medial lemniscus tract to the higher centers. And the ones that are relevant for pain processing are essentially the periaqueductal grade, the thalamus, the somatosensory cortex, and the anterior cingulate gyrus. This table quite nicely summarizes the different types of neuromodulation that have been trialed in managing bladder pain and chronic pelvic pain. As urologists, gynecologists and nurses in the area, we're quite familiar with Ptns, percutaneous tibial nerve stimulation, and the newer technologies include implantable tibial nerve stimulators and also sacral neuromodulation. However, there have been studies addressing dorsal root ganglion stimulation, spinal cord stimulation, which is more in the realm normally of our pain colleagues, and then even higher center stimulation in the form of motor cortex and deep brain stimulation. As expected, the evidence in this area is very limited, and there are some advantages and disadvantages to the various techniques. What we're more familiar with are perhaps these forms of neuromodulation: TENS, Ptns, and sacral nerve stimulation. The theory about how neuromodulation helps with pain really comes from the theory of gate control from Melzack and Wall, where the basic principle of stimulation of larger myelinated afferent nerve fibers can inhibit these smaller nociceptive fibers. But I think it's still fair to say in 2020 the full mechanics of the mechanisms are not fully understood. If we look now at the International Continence Society's best practice statement for the use of sacral neuromodulation, what they've suggested is that there's limited evidence in the use of this technology in managing interstitial cystitis and bladder pain. However, it is an option. They did go on to say there's a lack of evidence supporting it, however, for non-interstitial cystitis bladder pain syndromes, i.e. other causes of pelvic pain. Our group have recently published the Guideline of Guidelines on bladder pain syndrome, and essentially most guidelines are in sync in that it should be considered in refractory cases and prior to radical surgery. If we look at this table, these are the various guidelines: the EAU, AUA, International Consultation on Incontinence, East Asian Royal College of Obstetricians and Gynecologists, and the Canadian Urological Association. Most grades of recommendation are C or D, and the EAU recommended as a grade B recommendation. This was a very nice systematic review of the literature on the use of sacral and percutaneous tibial neuromodulation in managing non-neurogenic lower urinary tract dysfunction and chronic pelvic pain, and there was sections on bladder pain, interstitial cystitis in particular. This has come from Dirk de Ridder's group, and really their criteria for inclusion was fairly robust in that randomized control trials were included, although they acknowledged there is a lack of this in the literature in neuromodulation in general. Prospective trials or retrospective studies with at least 20 patients and at least 6 months follow-up were included, where they had assessment of efficacy and adverse events. And with regards to bladder pain and interstitial cystitis, only one study made the criteria. This was the Dmochowski study from 2011. In this study, they showed that using the Global Response Assessment Scale, there was an 80% average improvement in their patient cohort, which was only 44 patients. Success rate, if you include the trial phase, was 43%, however. I think this systematic review really highlights where we are in 2020 with neuromodulation in this field, in that there is a lack of high quality evidence. At the ICI-RS meeting in 2017, again they looked at refractory overactive bladder options, including botulinum toxin A and sacral neuromodulation in managing interstitial cystitis and bladder pain. What you can see from the table is that the included studies had very few cases. You can see here very low numbers. The largest series here included 78 patients. Follow-up was reasonable, and treatment outcomes, predominantly using VAS scores or visual analog pain scores, were quite variable, with improvements seen in as low as 35% and as high as 77%. Explantation of devices was also quite variable, again varying between 0 and 50%. Wang et al. In 2017 published this meta-analysis and systematic review of the literature, again with refractory bladder pain and interstitial cystitis specifically. What's interesting to note that in their particular study they included all the techniques involved, and it's interesting to see that although we're quite familiar with unilateral S3 transforaminal sacral nerve stimulation, there were several studies which utilized bilateral techniques. Furthermore, there was only one randomized control trial in the entire review, and this was a randomized trial of pudendal nerve stimulation versus sacral neuromodulation. Again, we can see the patient numbers are very limited. In summary, there was one randomized control trial, 8 prospective studies and 8 retrospective ones. Predominantly, patients were recruited based on NIDDK criteria or cystoscopy. In a couple of studies, there was no clear definition of the recruitment policy. As expected, the majority of patients were women in 89%. The primary outcome was to look at visual analog scores, and looking at the meta-analysis, overall there was an almost minus 3.9 reduction in VAS scores if you looked at all the data in the analysis. Success rates based on 10 studies were quite variable between 60 and 98%, and the pooled analysis suggested it was 84%. If we look now at the secondary outcomes, there were improvements also seen for storage LUTs in the form of daytime frequency, nocturia and urgency. Complications vary between 0 and 56% with an explantation rate of 8%. When they looked at the sub-analysis, long-term success was still seen in 76%. This was the randomized control trial we talked about earlier between pudendal and sacral nerve stimulation, and really since 2007 there's very little in the literature about pudendal neuromodulation in this field. However, it's quite interesting to note that regardless of the technique, either sacral versus pudendal, the improvements in voids per 24 hours were very similar, i.e. statistically significant benefit for sacral nerve stimulation as well as pudendal. When we look at now the pain based on the PUF scores and the O'Leary-Sant scores, there were significant improvements, again with both techniques, with no difference between the two. However, if patients were asked to choose, 77% would choose pudendal nerve versus 24% sacral nerve. We're now going to move to percutaneous tibial nerve stimulation for BPS and IC. What we can see really is that the available study, this is a recent study by Sudol et al., but again very low numbers. In this particular case there was only follow-up with 10 patients. GRA scores were at best 40% at the early follow-up and 30% improvement at the longer term follow-up. The paper included a very nice summary table of the literature of PTNS for this indication, and in general the results in my view have been relatively poor. Many of the studies showing no significant change in assessment scores, although some studies suggesting 60% response based on visual analog and 40% response based on subjective measures. So the data really is very mixed. If we move now to chronic pelvic pain, we can see there's a tremendous amount of etiology here. Chung and Stones in the past have suggested PID, pelvic inflammatory disease, bladder pain, irritable bowel syndrome, adhesions, entrapment syndromes and musculoskeletal, and then gynecological conditions such as endometriosis. More recently, the U-point system has been developed by Curtis Nickel, where we can break down pain, chronic pelvic pain, into urinary, psychosocial, organ-specific, infection, neurological, and focal tenderness. The EAU guidelines have broken down chronic pelvic pain into various organ-specific syndromes: prostate pain, bladder pain, scrotal pain, urethral pain, vaginal and vulval pain, and now in relation to the mesh current issues, pain related to mesh use. Again, if we go back to the Tutolo et al. Systematic review, they also covered percutaneous tibial nerve stimulation. We can see only 2 studies met their criteria. 89 patients essentially with chronic prostatitis with visual analog score improvement in around 40% with use of PTNS. And only one other study, again a small study with 24 patients with improvements in visual analog scores. Very recently in European Urology Focus now we have another systematic review focusing specifically on chronic pelvic pain. Again, very robust PRISMA guidelines adhered to, and ultimately 36 studies were included in the analysis. This rather busy slide is really just to illustrate the different kind of pain syndromes that were reviewed. The DYS here stands for dysmenorrhea, IBS, irritable bowel syndrome, CPP, chronic pelvic pain syndrome, and PPS, prostate pain syndrome, i.e. chronic prostatitis. So quite a mixed group of pelvic pain syndromes. In the meta-analysis of RCTs, we can see the predominant technologies used were TENS or PTNS, with some statistically significant improvement in pain. If we go now to the non-randomized studies and focus specifically on interstitial cystitis, again significant improvements, and again significant improvements in the chronic pelvic pain group in terms of pain. The right-hand side forest plot indicates the technologies used. It's broken down here by the different types of neuromodulation, and regardless of the neuromodulation used, significant benefits were observed for peripheral nerve stimulation, Ptns, TENS, or sacral nerve stimulation. In those managed by sacral nerve stimulation, adverse events were reported in 0 to 50%. Reoperation was required in 11 to 50% for the usual reasons such as lead migration, malfunction, infection, erosion, and loss of efficacy. Ptns, as expected, very rarely had side effects or adverse events, but the analysis really commented on the poor quality of studies in the review. A lot of the studies were underpowered, heterogeneous group of patients as we would expect perhaps in a chronic pelvic pain group, and quality of life only represented in 50%. So I think it's clear, looking at the literature of recent years, that better data is still required. A lot of the studies have been small studies, either retrospective, and what we clearly need is better randomized controlled trials, or at least larger prospective studies. With regards to sacral nerve stimulation, it'd be quite interesting to understand a bit more, I think, about pudendal nerve, considering the results back from earlier studies and whether this can be developed with better techniques to access the pudendal nerve. In general, there is a feeling, I think, that with sacral nerve stimulation, there's no potential advantage of bilateral stimulation versus unilateral for overactive bladder and voiding dysfunction, but maybe that won't be the case for pain, and better level studies to address this may be reasonable. Types of stimulation also may be relevant here. We are focused on the sacrum, but actually if we learn from other specialties, perhaps we should be considering stimulation higher up the pathway in the cord, or perhaps even considering a combination of sacral and spinal stimulation. Many thanks for your attention. The next lecture is going to be on optimizing neuromodulation. My name is Arun Sahai. I'm a consultant neurological surgeon and honorary senior lecturer at Guy's Hospital in London and King's College London. These are my disclosures. The objectives are really going to focus on patient selection, some technical factors, and programming. I think it's quite important to select patients well if we want to get good results. There is a lot of evidence for neuromodulation, and in particular sacral neuromodulation, with regards to refractory overactive bladder, Fowler's syndrome, and non-obstructive urinary retention. However, even within these groups, there are many phenotypes of overactive bladder and voiding dysfunction. We often quote a greater than 50% reduction in symptoms for overactive bladder, but it begs the question, why? Because we could increase the criteria, we could increase the reduction if we wanted to get better results. So one option may be to consider a 70% improvement, for example. The other thing that I think is very relevant for overactive bladder is the hallmark symptoms, essentially of urinary urgency. But you may have OAB wet, and it's possible you'll have urinary urgency and urgency incontinence. And these are the symptoms I think that people should focus on in improvement. However, a lot of the literature would have suggested improvements in any overactive bladder symptoms, which include daytime frequency and nocturia, perhaps, may have in the past allowed you to go on to a second stage implant. The evidence base is quite mixed with the urodynamics in terms of what it does, the technology, i.e. neuromodulation, to urodynamic parameters. But I think what's becoming clear is that urodynamics are unable to predict outcomes. And really, the best way of predicting an outcome is the trial phase in sacral nerve stimulation. This nice study from UCLH in London really looked at urodynamic parameters to see whether any of them were prognostic. You can see here the two columns, first stage tine lead procedure success versus failure, and really there were very little differences in the urodynamic parameters assessed. They also looked at the effects of compliance, and again, no significant differences were observed. However, I don't think urodynamics are able to predict the outcomes, but they're certainly useful for selection in my view. For example, what we talked about earlier with overactive bladder phenotyping, we know that several patients will have bladder oversensitivity, i.e. without evidence of overactivity. And perhaps patients may or may not do as well with neuromodulation if Detrusor overactivity is not proven. With regards to voiding dysfunction, we certainly know acontractile detrusors don't particularly or tend to do well with neuromodulation. And voiding, or sorry, should I say video urodynamics, are often very helpful at delineating the etiology of voiding dysfunction, whether there's a high tone non-relaxing sphincter, for example, versus outflow obstruction or detrusor underactivity. The future study, which is really an interesting study assessing urodynamics and their utility in patients with refractory overactive bladder, is going to be very informative. This study randomizes patients to urodynamics or not before they go on to have botulinum toxin or sacral neuromodulation treatments, and we eagerly await the results in the future. I think if we want to optimize neuromodulation, we've really got to get the technique right. I think there's emerging and consistent evidence that good technique, and it's also logical, will lead to good outcomes. The International Continence Society Best Practice Statement very clearly illustrates the optimum technique. Whether you use a P&E approach or a two-staged approach will be dependent on your particular circumstances and your preferences. If you use a first stage tie and lead approach, which has some advantage in terms of number of implants, the trial period needs to be appropriate. Typically this will be between 2 to 4 weeks. But if there's not particularly good effect with the initial programming, there needs to be enough time to trial different programs to try to understand if the technique will be successful. When you're actually on the table, it's best if you can get motor and sensory responses on all 4 contacts at less than 2 volts. This will certainly give you a number of options with programming in the future, but also it's clear will lead to better outcomes straight away. It's important to try to cannulate the S3 foramen. Although S4 is possible, it's not preferred. With regards to sensations, we want to avoid sensations down the leg and buttock or particular discomfort in the genitals. However, sensation or tingling felt in the genital area is appropriate. The gold standard of the first stage technique would include the use of fluoroscopy and using APN lateral views. And the IPG placement should typically be in the lower back, upper buttock, but occasionally can be in the abdomen. And clear patient advice is instrumental to hoping for good results. Appropriate counselling and consenting and knowledge prior to the procedure, but also more importantly, how to manage the device in the trial phase is critical. All patients will need a route back in to discuss problems if we want to optimize the outcomes. We mentioned earlier about the advantages and disadvantages of P&E versus first stage technique. I personally prefer the first stage tie and lead approach, mainly because the test success rates seem to be significantly higher. But furthermore, I do appreciate that it's perfectly possible to do this with a P&E approach, which has the significant advantages of being possible in the outpatient setting, for example, and likely to be more cost effective. If we go back to the technique again, on the table, it's key that there's no significant lordosis, and the positioning is important if we want to get access well to the S3 foramen. Radiological marking and the use of fluoroscopy is really the key, and this transverse line depicted at the bottom of the SI joints typically marks out the S3 foramen. The optimal axis will be the cranial medial edge, and of note is the use of the curved stylet, which has been introduced over the last 5 to 8 years or so. You can see here in these pictures we're looking for at least 3 contacts beyond the anterior border of the sacrum, and the curved stylet allows for a more logical alignment of the electrodes with the S3 nerve root. This is a picture again of the curved stylet in comparison to the old tined lead. This has been assessed in a study here with 2 years follow-up by Vigani et al. In this particular study, there were significantly better outcomes for the curved stylet group versus the straight stylet group in terms of successful tests, which was quite dramatic at 94% versus 65%. Successful outcome at 12 months was 94% versus 65%, and again, successful outcomes at 24 months, 91% versus 45%. If we looked at sensory stimulation in the 2 groups, what they deemed as the sensory passport, the optimal sensations were reported in approximately 60% in the curved stylet group compared to 40% in the straight group. Poor sensations in a quarter in the stylet group compared with 37% in the straight stylet group. So I think it's fairly clear that the curved stylet is a significant advance to the technique. But as we're going to hear in the next lecture, there's a significant amount of innovation and technology in the field in the recent years. We now have smaller devices which are rechargeable and MRI compatible. This is the Medtronic micro device and the Axonics system. We also now have implantable tibial nerve stimulators as highlighted in these 3 pictures. What would be interesting with regards to sacral nerve stimulation is whether these smaller devices lead to better tolerability. I think the hope is the efficacy will remain as per the old systems, but actually perhaps the relevance of pain, particularly at the battery site, may be reduced if there's a smaller device, but time will tell. This troubleshooting flowchart was produced by the ICS Best Practice Statement on Neuromodulation and really is a useful flowchart for troubleshooting SNS devices. If there's loss of efficacy, one should check the stimulation parameters, make sure the IPG is not off, and of course if it is, turn it back on. If it's on, has it got a normal battery life? And if so, then reprogramming can be done with hopefully success. But if not, then we should consider some imaging in the form of X-rays to check for lead migration or fracture. And again, then repeat programming if placement appears correct. However, if not, revision may be required. With regards to programming, you can see here the neuromodulation is delivered at the negative electrode. And devices come with these 7 standard configurations which give stimulation at the various contacts, either 0, 1, 2 or 3, as depicted based on the programming parameters. If we want to get a slightly wider field, we can actually put 2 negative parameters to cover a slightly wider area as depicted here, here and here by placing 2 negative electrodes at 2 in series. So we can see based on the 7 programs that all 4 contacts can be covered individually or with a slightly wider spectrum as depicted by the last 3, 5, 6 and 7. And these are the standard programming parameters that are available on the new devices. But other programming options are available should none of these work. So in summary, I think if we want to optimize neuromodulation, we should go before the procedure and make sure the patient selection is accurate and good. We must adhere to the best practice guidelines of technique and use the curved stylet, and I would suggest anyone interested in this field should read the ICS best practice statement on neuromodulation. It'll be interesting to see whether the new technologies translate into better tolerability. The urodynamics, I think the evidence would suggest at the moment they're very helpful for counselling and phenotyping patients well, but are not as useful at the moment for predicting outcomes. The future study, however, would be interesting. There is guidance, should I say, on troubleshooting with regards to neuromodulation, and the flowchart I showed I think should be adhered to before abandoning treatment. In the future, like I said, it will be interesting to understand the new technologies and how they would help in terms of optimizing the outcomes, but there's a lot of things that need to be trialed and a lot of things that we can learn from our colleagues in other specialities. For example, bilateral stimulation, using alternative frequencies, intermittent stimulation, for example, different frequency patterns such as burst or high frequency, and the different types of neuromodulation and their location in the cord. Many thanks for your attention.
Hello again, my name is Marcio Averbeck. Let me share my slides with you. So the topic of this lecture is new technologies, innovations, and the future, which is a rather challenging topic, and I promise I'll do my best to bring new insights, especially for you. These are my disclosures. This is Porto Alegre, the city where I'm living in the southern region of Brazil, the main city actually in the southern region of the country. And in this picture, you can see the University Hospital and the Federal University of Health Sciences of Porto Alegre. Topics of my lecture include neuro S&M technological developments and implantable tibial nerve devices. Before addressing these topics, I'd like to introduce to you this patient. She's a MS patient, 40 years old, EDSS 1 point. Her main complaint was mixed LUTs, storage predominant LUTs. She has recently come to my office looking for a second opinion. She has brought urodynamics showing neurogenic detrusor overactivity, and EMG suggested the detrusor sphincter dysynergia with a post-void residual volume of 80 mLs. She has failed 2 antimuscarinics prior, including oxybutynin, tolterodine, and also more recently the beta-3 agonist mirabegram. She's concerned about the risk of urinary retention related to the treatment of botulinum toxin A, which has been proposed by another colleague. The question here is, what should we do? By the way, the neurologist anticipated that she has some MRI imaging planned for the near future. I'll come back to this clinical case afterwards. Let's start with neuro S&M technological developments. This is an article I had the privilege to publish on the International Brazilian Journal of Urology, along with colleagues from Mexico, Dr. Jorge Moreno Palacios, and also Dr. Alejandro Aparicio from Colombia. We've reviewed all series on sacral neuromodulation, which were published as of 2011, and found some interesting outcomes here. Just to illustrate some of the limitations, take a look at the numbers. Very restricted number of patients included in these studies. As a first take-home message, take a look at the outcomes, which were poor for patients with spinal dysraphism, and most probably this is not a good indication for sacral neuromodulation. However, further studies are still needed. And take a look at this publication by Minardi et al., showing that S&M did not help MS patients with urinary retention due to the detrusor underactivity. So according to these authors, most probably the benefits are more clear for patients with DSD. However, I just brought these insights to illustrate how important are the inclusion criteria and also the criteria for a successful test phase and for a longer term follow-up, because you should be aware about the different patterns of urinary tract dysfunction in these patients with neurological diseases. We should know whether they present either with neurogenic detrusor overactivity, with or without detrusor sphincter dysynergia, whether there is evidence of Detrusor underactivity as well. So these are important points, and without these criteria, most probably we won't be able to improve the level of evidence for this specific technique among these patients. So this is something that came to add to the clinical practice. So this sacral neuromodulation system has been launched by Medtronic internationally and is already available in some countries, as in North America and in some European countries. On the left-hand side, you can see the InterStim2, the regular device, which is being available in the market for a while. And on the right-hand side, you can see the InterStim Micro, which is the rechargeable device and 3 Tesla full-body MRI compatible. So this is something that we are still looking forward in Latin America because it's not available at this moment. We found some interesting outcomes and concluded that SNM seems a promising therapy for neurogenic Detrusor lower urinary tract dysfunction in carefully selected patients with incomplete lesions, but further studies are still needed to define which subgroup of neurological patients benefit the most from this minimally invasive technique. I cannot forget mentioning the newer SNM device, which has been developed by Axonics, the Axonics Air SNM, implantable pulse generator on the left-hand side, and also the therapy controller on the right-hand side, as you can see in this slide. More recently, we had some trials assessing the efficacy and safety of this device in the clinical practice, especially for those patients with idiopathic dysfunctions. We have plenty of evidence to suggest that the InterStim2 device by Medtronic is effective and safe at the longer term because most of the studies addressed this neuromodulation system provided by Medtronic, developed by Medtronic. But now I'm going to bring some evidences of this system by Axonics. This was a study published by Benson et al., showing one-year outcomes of the Artisan SNM study for patients with OAB. As you can see here, these are very promising outcomes. Around 90% of the patients presented with good results at 1 year follow-up. And the episodes of urinary incontinence per day dropped from 5.6 to 1.5 at 1 year follow-up. And around 30% of the patients were completely dry. Block et al. Have published these outcomes, which look at a longer-term follow-up, 2-year follow-up safety and efficacy for this newer Axonic system. As you can see here, they stratified the results not only for OAB in general, but also for urinary incontinence in urgency frequency, showing that this was safe and provided marked benefits for the patients included in this trial, which was a multi-centric trial at 2-year follow-up. The subjects were satisfied with their therapy and reported that recharging experience was acceptable. This is something that we should bear in mind because some of the patients, even though they can choose between rechargeable and non-rechargeable device, this is something that should be aligned with the patient when we indicate the SNM therapy as a third-line therapy for these patients. Additionally, no unanticipated device-related adverse events were reported. This is a very interesting finding as well at the 2-year follow-up. Let's move forward. What about the implantable tibial nerve devices? We know that Ptns for patients with idiopathic OAB represent some benefits for the clinical practice in the armamentarium for treating these patients. And it's a non-invasive therapy, similar efficacy to medications without the typical side effects of antimuscarinics, for example. However, Ptns requires 12 weekly sessions plus monthly maintenance therapy usually. and it's not indicated for fecal incontinence or urinary retention. So there are some barriers that make the need for frequent visits to receive this therapy not feasible for most of the patients in the clinical practice. I had the chance to publish this review article along with these colleagues from the Cleveland Clinic, Dr. Juan Guzman-Negron and Professor Howard Goldman. And as an acknowledgement, I'm bringing a video here of an implantable tibial nerve device, which has been provided by Professor Goldman, which assessed the Ptns device. And this is a very short video, so please take a look at this. The position and exposure, we can find the nerve and the anatomical landmarks with ultrasound and this probe just before making the incision. We can perform it easily under local anesthesia. And this is the test probe, which goes along the tibial nerve. Of course, we should demonstrate the plantar flexion of the great toe, showing that the probe is nearby the nerve. This is the kit, implantable kit, which is used to pass the receiver through the needle. And it's it's a procedure which can be done very fastly, and it seems very promising as well. This is another device. This is a publication with a 12-month follow-up by For van der Paal et al., showing that there are some different devices which can be used. And of course, they are not widely available in many countries, but it seems that these newer devices are providing benefits in terms of comfort to deliver the therapy. So according to this publication, at the 12-month follow-up, there were statistically significant differences in terms of the number of urinary incontinence episodes and also the quality of life scores for those patients who received the implantable tibial nerve device. As take-home messages, the most recent technological advances will surely influence the indications for sacral neuromodulation in patients with neurological diseases, since MRI compatibility makes monitoring of these patients much easier. The implantable tibial nerve devices have been recently proposed, and further studies are still needed in patients with neurogenic urinary tract dysfunction. Coming back to the clinical case, which I've addressed initially, this patient who is concerned about the risk of urinary retention related to the treatment of botulinum toxin A might most probably benefit from MRI-compatible sacral neuromodulation device, which nowadays is not widely available in many countries, including Latin America, but we're looking forward to having these technologies, the newer technologies in the armamentarium for treating these patients more effectively. At last, but not the least, I would like to congratulate Professor Arun Sahai for pushing this workshop initiative forward, and thank you all for your attention.